Good morning. Thank you. Thank you for your attention. And as we've heard this morning, there's a tsunami of heart failure. And it's good to see that hopefully there are some new therapies. But in the meantime, we are faced with an overwhelming number of patients with heart failure, particularly in the Southeast United States. There's no shortage of morbid obesity, end-stage diabetes, and hypertension. So over the last 10 years or so, VA ECMO has been used as a bridge to both LVAD and heart transplantation. The approach has been controversial in that the results have been initially pretty poor. A review of the ELSO registry showed that the in-hospital mortality was about 29%. So given that, in 2018 in the United States, UNOS, which is the United Network for Organ Sharing, changed their allocation policy such that patients that were placed on ECMO would go to the top of their blood group list. And these are patients that are failing Impellas, inotropic support, and other entities, and are really starting to slide. So this is a review of the Spanish data. It's from 2010 to 2015, and it went over 16 institutions in Spain. And at the time of listing, 58% of their patients were supported on VA ECMO support. And as you can see and go down there, the in-hospital mortality after transplant was 33% coming off of VA ECMO. It was a little better probably coming off of an Impella, but still not what you'd hope for. And overall survival from listing to hospital discharge, it's hidden by the bottom line there, but it was only 54%. So this is a study, a review out of, France, out of the Crystal Registry, again, where they showed that a lower one-year survival in patients bridged off of ECMO to transplantation was only 52%. So this is where people were afraid of doing transplantation directly off of ECMO support. And one final one, this is from last year in clinical transplantation. This is out of Argentina, again, from 2014 to 2022. And what they did is they had an overall in-hospital mortality of 50%. So they originally had 22 patients that were bridged to transplantation. 11 of them died. Out of the patients that got transplanted, 9 out of 10 were discharged, which was an increase in survival from what was reported. So this is out of Vanderbilt. They did a review of the UNOS and Intermax data, and this was 116 patients were bridged in era one being pre-2018 and era 2 being post-2018. And so they showed an increased 30-day, 6-month, and 1-year survival in the new era. So this was encouraging data that transplanting off of ECMO may, in fact, be beneficial. So we got interested in looking at our data. And what we did is we went back and we started our ECMO program in about 2010. And we've grown almost exponentially in that amount of time. This data ends at 2023, but last year we did 103 transplants and 92 LVAD implantations, and year to date, we've done 115 LVADs this year and 80 transplants so far. So what this, our most recent data is, well, even since I submitted this on August 25th, we had 55 transplants off VA ECMO. From 2022, we're now up to 60. We've done another 5 in the last 2 weeks. And our survival to discharge is 96%, and 1 year survival is 94.7%. So it is possible to do this and get good outcomes, even in people that are really sliding and slipping. And again, most of our preferred cannulation technique is VA ECMO support. We do a bunch of remote cannulations throughout the state of Georgia and in Tennessee and Alabama. And the safest means of transport is to put these people on VA support. You have full cardiac and respiratory, and you're covered. You don't want something to go wrong in an ambulance or an airplane, because I've had that happen, and we can just tell you it's not pleasant. So what we did is we've had 55 transplants come off of ECMO support. Median age is about 52 years. Majority were male. Most of the patients were African American, and BMI upwards of 30. So class 1 obesity up to also class 2 obesity. We have done some people. All these people are femorally cannulated, 100%. Our preferred cannulation is left femoral artery, left femoral vein, and left SFA. That leaves the right groin open for our interventional cardiologist or our structural cardiologist should they need to do something. It also makes it safer for transport in an ambulance. You have access to that groin easier than the right groin. And 47, it's kind of hidden down there, but 47% of our patients had left atrial vents. That's our preferred venting strategy. If we get a patient that has an impella, we'll leave it in, turn it down to about P2, P3, and we won't pull it out. But it's a, at least in the States, that's about a $50,000 device. And if they don't have an impella, we'll go ahead and put in a left atrial vent, go up across the foraminal valley, or get one of our structuralists to put a Lunderquist wire across that and put a vent in. It's a $1,500 cannula versus a $50,000 device. At some point, you do have to be a good steward of resources. So that's the reason for that. So there's no magic to this, but if there is, it would be get these people up and walking. And a lot of programs may have difficulty. This is a double amputee, diabetic who had foot ulcers, wound up losing his legs. He's groin cannulated, VA ECMO support. He's on CRRT and he's on nitric oxide. We extubated him, and you got to get these people moving. You will get a lot of pushback from your hospital administrators, your nursing staff, and your physical therapists. But get physical therapists that are interested in cardiovascular physiology, but you got to get these people moving. That's our physical therapist doing the least amount of work. Respiratory with the nitric oxide, and perfusion is in front, leading the way. But as you know, the longer you're in bed, the weaker you get, the longer you're in bed, and you're in a spiral. And so this is really one of the keys we found out. The other is to diurese your patients very aggressively. As you all know, most of these people are waterlogged, probably have 15 to 30 liters because they're in stage D heart failure. We just had a gentleman who is 6'8", 350 pounds, blood type O. He was cannulated for 48 days on VA ECMO support till a donor could, a reasonable size comparison could become available. And we diuresed 48 liters off of him. So the point is, be uber aggressive with these people. It can be done. It is safe to ambulate these folks. And just, there is no shortage of patients, at least where I am. And we're so far behind the curve. As you know, everybody that's admitted 2 times a year for heart failure has a 50% mortality rate in the next 5 years. So don't give up hope, keep at it, and keep pushing your teams. And the other thing is that we think that probably we limit the number of people that take care of these ECMO patients. There are some centers that will change people weekly. We tend not to do that. We have a core group of people that take care of these folks, and we think that's important as well. But don't be afraid to push your institutions for more. I'd be happy to answer any questions.